Viswateja from Patil Medical College, Bijapur. Here a patient named Basamma, Patil Medical College, Bijapur. Here a patient named Basamma, aged 10 years, school-going child, came to the dermatology OPD with complaint of dark colored skin lesions over the face, trunk and neck. She was examined. First, if a patient has come to a dermatology OPD, when K-foliate spots were seen over the cheek, there is NIH diagnostic criteria, where if two criteria is accepted, it is confirmed as neurofibromatosis. But to finalize it, there is some referral option. So they had referred to ophthalmology OPD for slit lamp examination. Why? Because the clinical criteria of neurofibromatosis type 1, more than 6 K-foliate spots, greater than 5 millimeters in greatest diameter in pre-pubertal individuals, and greater than 15 millimeters in greatest diameter in post-pubertal individuals. And coming to the ophthalmologic side, optic glioma and lesion nodules, those are the iris hamartomas, were one of the clinical criteria. So after cutaneous examination, they have referred to ophthalmology for lesion nodules. Neurofibromatosis, a autosomal dominant and a multi-system genetic disorder affecting 1 in 3,500 people, and it is mainly caused by mutation of the neurofibromin gene that is on the long arm of the chromosome 17 that codes for the protein product neurofibromin that plays a major role in regulating the GPES triphosphate activity that controls the cell signaling and cell differentiation. And the major symptoms coming to neurofibromatosis were K-foliate macules, lesion nodules in the iris, axillary freckling, and there will be long bone dysplasia. And coming to the orthopedic problems, there will be lateral curvature of the spine known as scoliosis. And coming to the optic glioma also will be seen, and learning disability is observed. History of presenting illness. Patient was apparently alright 1 month back, then developed dark colored skin lesions over the face, neck, chest, which were insidious in onset and gradually progressive in nature, and with a complaint of lesions gradually increasing in size and coalesced to form a large plaque, swelling over the right cheek with above onset is seen. And there is no history of delayed milestone, visual disturbances, pain, itching, and recurrent fractures of the weight bearing bones, and no history of similar complaints. And here is the chart. 10 years baby is affected, and here is young school-going age children, moderately built and nourished, conscious, cooperative, well-oriented to time, place, and person, and GPE, facial symmetry, asymmetrical, and face turn is absent. Respiration rate 16 cycles, blood pressure 110/78 mm of Hg, pulse rate is 78, and temperature is 38.6 Celsius, and there is no pallorus, icterus, cyanosis, clubbing, and lymphadenopathy. Coming to cutaneous examination, multiple well-defined hypo or hyperpigmented patches of the size 5 and greater than 5, and peaks of variable size present over the back, left nipple area, right shoulder, and right side of the face. Later having a baggy swelling and a sagging down, giving a facial asymmetry. And axillary freckling was present over axillary area. Coming to the ocular examination, visual acuity is normal, eyelids position were normal, but lid margin is S-shaped. Sclera, there is discoloration, that is muddy, and nodules were absent. Iris, where is the important thing, color, it is brownish and pattern is radiating, but lesion nodules were seen in the lower pole of iris. Coming to the differential diagnosis, it may be McBurn-Albright syndrome, tuberous sclerosis, Silver-Russell syndrome, Legas syndrome, and Gaucher's disease. And patient has investigations of plain X-ray where no abnormality was seen in the long bones. MRI with aberrant myelination is noted, and slit lamp examination, lesion nodules were seen bilaterally. Treatment is pulsed laser dye therapy and topical treatment and psychotherapy and cognitive behavior therapy. Prognosis, it cannot be predicted, but individual variation is seen. Every year for ruling out cataract and for mental disability is follow-up. Coming to the ocular manifestation neurofibromatosis type 1, they were congenital ptosis, lesion nodules, retinal hamartomas, optic glioma, and decreased visual acuity. Lesion nodules are the melanocytic hamartomas that appear as a well-defined dome-shaped elevations projecting from the surface of the iris, which were clear brown, yellow to brown. Multiple lesion nodules are found in NF1 patient. A slit lamp examination is required to distinguish them from a navy of the iris, which were flat and are minimally elevated, densely pigmented lesions with the blurred margins. Conditions where we find lesion nodules other than the neurofibromatosis type 1 are iris mammillations, multiple iris nevi, iris melanoma, granulomatous iritis, iris cyst, retinoblastoma, Brushfield flex, and ICE syndrome. And in a study conducted on 120 families with neurofibromatosis type 1, out of 167 patients, the overall prevalence of the lesion nodules is 73.7%. if lesion nodules and neurofibromas can be seen, but before the prevalence of the neurofibromas, the lesion nodules were be identified. In 5% of and in children less than 3 years, it is 5%, and from 3 to 4, it is 42. Whereas coming to the children 5 to 6 years, it is 55%, and more than 20 years, 100% lesion nodules were seen. And lesion nodule manifests in early childhood and present in 95% of adults with neurofibromatosis type 1 and easily seen in slit lamp examination. And as if this neurofibromatosis covers all of the aspects, but a easy, inexpensive and a diagnostic tool for the early diagnosis of neurofibromatosis type 1 coming to the ophthalmologic side is lesion nodules in the lower pole of iris. And if a child with multiple K-foliate spots found to have lesion nodules, the diagnosis is confirmed as NF1. Thank you.
Can you get back to the slide various diseases associated with lesion nodules? Button. Lesion nodules are seen, you said. Can you tell me, differentiate? Is it possible?
Sir?
Is it possible to differentiate by any other means of these things? Associated things where you can exclude. Cogan-Rees syndrome.
Sir?
Cogan-Rees, suppose, take the last one, Cogan-Rees syndrome. Take the last one, there. And can you, okay, fine. You are
Yes,
looking
sir.
at the term. Any other means of excluding it? What are the other things you see in that syndrome? The retinoblastoma. Granulomatous iris.
Like neurofibromas, sir. Neurofibromas, lesion nodules were...
Lesion nodules are quite, no inflammatory signs seen in granulomatous iritis. Okay, fine. You have listed it for the sake of it. Okay, fine.
Classify the neurofibromas. Classification.
Plexiform neurofibroma, sir. Segmental neurofibroma. Cutaneous.
Type 1, type
2. Neurofibromas type 1 and type 2, sir. Type 1 is more common, and it is also called von Reckling-Hassen's disease. And lesion nodules were seen only in NF1, whereas absent in NF2.
Neurofibromatosis is clinically you diagnose by basic lesions, okay? Multiple nodules all over the body. Type neurofibromatosis, multiple neuroma and fibromas are there all over the body. Condition, you know, where we'll get multiple nodules for the body.
Yes, ma'am. In Legas syndrome,
Sorry?
Legas syndrome, Proteus syndrome, and McBurn-Albright syndrome.
They're all similar appearance? I don't think. Only condition where multiple lipomas are there, all the body. If clusters lipoma, then we can think of similar
In some
to
conditions,
neurofibromatosis.
hyperpigmentation.
Everywhere it is not hardened past hyperpigmentation is must. Okay. So sometime it may be lesions. Another condition may be cystadenoma multiplex, where adenomas are multiple and in clusters like in neurofibromatosis.
Any doubts from the audience side? Yeah, thank you. Thank you all the participants for your participation and a few of them for your active. It made the session lively. Thank you so much. And we apologize for all technical matters. And judges, we apologize.